aprotinin story is a very, very interesting one. And it started very innocently in our hospital. We were asked by the Pharmacy and Therapy Committee to justify the use of aprotinin because it was so much more expensive. And we used it in a subset of patients who we thought were very, very high risk. Not high risk, but very, very high risk. And we're talking about more than a third thoracotomy, triple valve, or bacterial endocarditis, or heart transplants. And our use was very minimal. I think in the 10,000 patients in our database at that time, we'd only used it about 300 times. So when we did that, we did a propensity analysis and matched our patients who used aprotinin to those who did not, and got up and matched something like 150 patients and found that aprotinin was probably harmful. There was a third of the patients, about 50 patients, who we could not match because they were so high risk. We wrote a paper that came out exactly the same time as Mangano's and basically showed exactly the same story that Mangano was saying, that aprotinin looked like it was causing renal failure and might be associated with death. In our discussion, we said, however, we can't rule out that there is a beneficial effect in high-risk patients because we can't match those. And if you go back and look at Mangano's work, he could only show it in his low-risk patients. He dichotomized it into two risk strata, and in his high-risk patients couldn't show that aprotinin was bad. BART came out and showed exactly the same type of result. The interesting thing about BART is the population in BART, while it was supposed to be high risk, it didn't include the very high-risk patients that we were talking about. So we ended up with three pieces of evidence, all giving us the same piece of evidence. The reaction of the industry and the world was that aprotinin was taken off the market. Many people have come to me since that time and told me what a mistake that's been, because they knew for sure that aprotinin was beneficial. What's happened, though, is now that aprotinin's off the market, we've been forced to use it in those very high-risk patients, and we can match it now to those patients we couldn't before. And in fact, now we can show that in that very, very high-risk population that they're in fact a benefit. And in fact, aprotinin reduces both massive blood transfusion and mortality. And that shows the problem with randomized trials and risk in general. Is people think of it as a static thing. It's not. It's a dynamic thing, and for in any population, there's a variety of different risks that you have to take into account. And the randomized controlled trial does not embrace that, and the non-randomized trial does. Okay. The current rating systems actually give the randomized controlled trial of the gold standard, and there is a hierarchy of the types of evidence that we use to make decisions, and I'm not sure that that's justified. I think that there is lots of trouble with RCTs, and not just with the fact that they're expensive and they take a long time to do, but they're dependent on design, and they answer one question. And many times the question becomes irrelevant over the period of time that it takes to do the trial. And then they get sort of used to make different decisions after, and really have very little to do with the question that was originally asked. A meta-analysis by Ioannidis, and they actually showed they went out and did a meta-analysis and decided to look for areas where there was evidence for a meta-analysis of randomized trials versus a non-randomized trial, and basically showed equivalence between them. There were something like six of those 47 areas that they found that the difference between the level of estimate was outside, which would be predicted by chance, and of those only one disagreed in terms of the direction of the response. Sort of most of the things were the non-randomized trial overestimated an effect, but it was in the same direction in both cases. So in fact, the evidence is pretty clear that a well-conducted non-randomized trial gives the same type of evidence as the randomized controlled trial. The guidelines for non-randomized trials, which should be followed in every case, are the strobe guidelines, and they can be seen at www.strobestatement.com. It's a 22-item checklist which highlights what should be done for non-randomized trials. And if you follow that in terms of the methodology, you will come up with a fairly high-quality non-randomized trial. And the major points that really have to be followed is in the methodology. Describe what the patient population is, what are the outcomes, and are they outcomes that you're sure are true, and how do you, and when you model, are you taking into account all of the important confounding variables, and finally, how are you adjusting for the inherent bias in the two populations of interest.